Hi guys, welcome back. We shall now be talking about aspects related to heart sounds, which is a very simple and a straightforward topic. But if you are confident about this, you will be able to solve questions in a better fashion. So try to hand draw the first 5 line diagrams with me. In the first diagram, I shall be showing atrial systole. You can see that at the moment the tricuspid valve and the mitral valve is open, so atria will be contributing to filling of blood in the ventricles. Approximately 30% filling of the ventricles occurs in the phase of atrial systole. But once the atria have done the responsibility, the pressure in the atrial chamber will reduce, and therefore the mitral and the tricuspid valves will begin to close. Therefore, you will notice that in the second diagram, I am showing the development of first heart sound where mitral and tricuspid valves are exhibiting a closure. Now the pressure will tend to increase in the ventricles of the patient. However, this pressure will be incapable of opening either the aortic or the pulmonic valve. In this diagram, both aortic and pulmonic valve at the moment are still closed. So you can remember this stage as where no blood is coming in the heart and no blood is going out of the heart as isovolumetric contraction. There will also be a slight bulge of the tricuspid and mitral valves occurring during the phase of IVC because the pressure in the ventricular chamber is increasing. What I have just highlighted before you is first heart sound is present at the end of atrial systole, because you can see in atrial systole mitral and tricuspid valves are open. The moment the pressure will decrease at the end of atrial systole, mitral and tricuspid valve closure will be occurring, and what they're doing in the exam is that they're trying to link up physiology with internal medicine issues. So that's why we just have to look at this baseline information. Now the question that I'm putting up before you and was asked also, and the question said which heart sound is present after S1. Majority of guys simply thought that okay, after S1 is obviously going to be S2. But please appreciate that he was asking you a concept from physiology, which is the fact that when the pressure in the ventricles will increase dramatically, I've just put a bigger plus to highlight that the pressure in the ventricles is even higher now. So this higher pressure will cause opening of the aortic and the pulmonic valves, and therefore 80 ml blood will rush into the aorta, 80 ml blood into the pulmonary artery. The amount of blood going in both sides is precisely equal. Both ventricles fire at the same time. Why that is important? Because we will talk about conditions like bundle branch block, where left ventricle, right ventricle do not fire at the same time, and due to lack of coordination, they can be a pulmonary edema or pooling of blood in the lungs. So the amount of blood should go out to be equal and the firing should occur at the same time. This diagram that I've shown here before you is represented as ventricular systole. And the heart sound that have been highlighted at this particular point of time is called as ejection click, which occurs right after S1 and is called as aortic and pulmonic valve opening. Please appreciate that loud ejection click is a totally separate aspect. But at the moment we're talking about routine ejection click. Routine ejection click is aortic and pulmonic valve opening. So in the exam, if they ask you what is heard after S1, don't answer S2, rather answer it as ejection click, because all they are asking you is the sequence of cardiac cycle. They just want to know, or do you know the cardiac cycle sequence? So it is ejection click, and then subsequently what's going to happen next in the fourth diagram in the series will be that the pressure of the ventricles will begin to fall. If you compare the fourth diagram with the previous one, I am now showing that the bulge of the mitral and tricuspid valves will also disappear because blood has gone out into the aorta and pulmonary artery, so pressure is dissipated. The valves have come back to their normal position. At the same time, now the open aortic and pulmonic valves will also close. This closure is what I am interested in at the moment. This is development of second heart sound. This is called as S2, which is written as A2P2. Why? Because aortic valve always closes before the pulmonic valve, and the time lag between the aortic and pulmonic valve can also be heard physiologically, which is called as splitting of the second heart sound. The time lag between aortic and pulmonic valve closure is 30 milliseconds. The second heart sound has been represented during the phase of when the heart is beginning to relax. So this diagram represents what is called as isovolumetric relaxation. The blood is now trying to come back into the ventricles of the patient, but it will not be allowed permission to go into the ventricles. Why? Because at the moment the mitral and the tricuspid valves are closed. So IVR is the starting of relaxation, but at the moment the blood is not given permission to come in the ventricles of the patient. It will be, however, in the last diagram of this particular cardiac cycle that I represent, in which I will now be showing that the mitral and tricuspid valves will open. You can see As compared to the previous diagram, I have now shown rapid rush of blood. I am showing rapid ventricular filling occurring here. The blood is rushing into the ventricles of the patient, and at that point of time, or this particular movement, when the blood rushes into the ventricles, at that point when the mitral and the tricuspid valves are opening, the sound that is produced is technically called as opening snap. Please appreciate that loud opening snap is a feature of mitral stenosis that we will discuss separately. At the moment, I just want you to understand which heart sound is present after S2. Don't answer S3. Your answer is opening snap. We are studying simply the cardiac sequence, and that is that after second heart sound we have is a opening snap, which is mitral and tricuspid valve opening. The blood will now rush into the ventricles. Approximately 30% of filling of blood occurs in the phase of atrial systole, and the remaining 70% filling occurs in the phase of rapid ventricular filling. So you can see that maximum filling of blood occurs in the phase of diastole, and why that is important for you to know is because if the heart will beat very fast, then it will not be getting sufficient time to relax. If the heart will not relax properly, it will not get filled with blood, and if input is less, output will also be lesser. So the importance of understanding this hemodynamics or the sequence of events that I've just explained to you here is that first you hear a S1, then you hear a ejection click, then a second heart sound, then an opening snap in a patient. So whenever you are going to auscultate your patients, so therefore the sequence that is to be remembered by you is like this. This is the loved up heart sounds that we are able to auscultate, that is S1, S2 and S1. Period between S1 and S2 is called as systole. Why? Because right after S1 I taught you there is a ejection click. If you focus on the English word ejection, it means blood is going out of the heart. Period between S1 and S2 is referred to as systole. The remaining part would be called as diastole, and right after S2 you have is a opening snap occurring in the patient. It represents mitral and tricuspid valve opening because now the blood will be rushing into the ventricles of the patient. I want you to understand that the heart sounds that I've shown before you in color blue, they are all high pitch heart sounds. To hear them, you will have to use the bigger side of the stethoscope, that is the diaphragm. However, the ones that I'm showing you now is the third heart sound and the fourth heart sound. These are low pitch heart sounds. They are heard with the smaller side of the stethoscope, that would be referred to as the bell. From this description, you can also solve a question which said which heart sound is present right before S1, that would be fourth heart sound in the patient. Please appreciate that the question was asked like this. He said which of the following is a pre-systolic heart sound. He first wanted to see that are you aware what is systole, that is S1, S2. And once you know systole is S1, S2, systole starts with S1, the question was basically mean which of the following is a pre-systolic heart sound. That would be answered by you as fourth heart sound. I agree to the fact that normal physiology we have S1, S2, S1, that's the sequence, but in the exam he's asking you the sequence with respect to the cardiac cycle, so you anyway have to get used to it. The period between S2 to opening snap, this period is called as IVR, isovolumetric relaxation. Then the heart will start getting filled with blood. So in sync with physiology, we will call this phase of rapid ventricular filling. Maximum filling of blood in the heart occurs in the phase of rapid ventricular filling, after which there will be a short period which is referred to as diastasis. This is where the heart will be relatively motionless, I would say. This is the time when the heart will be having least motor activity, and the remaining part that I have highlighted in color yellow, this is the time of atrial systole. Atrial systole, as you can see, is the time when fourth heart sound is occurring in the patient, which explains the fact that why is it written in the textbook that fourth heart sound is called as atrial gallop rhythm. I will explain to you as we progress in the discussion what are the causes for development of fourth heart sound, but at the moment I just want you to understand that excessive force generated by the left atria, which is called as atrial kick or is called as atrial gallop rhythm, can be heard in the phase of atrial systole, whereas when it comes to third heart sound, that is heard in the phase of rapid ventricular filling, especially during turbulence. The alternative name for third heart sound is called as ventricular gallop rhythm, especially in patients who are having heart failure, because the heart is trying to beat very fast, there is turbulence, the heart is trying to clear the pulmonary edema component. That is why we can hear third heart sound, especially in patients of congestive heart failure. So once you get this basic sequence right, I mean, this is what is to be imprinted in your brain, the sequence that you should be aware of, that first there is S1, then ejection click, S2 opening snap, third heart sound, and fourth heart sound. Then we can talk about few additional aspects related to this basic infrastructure. Now, the additional aspect that I will explain to you can be understood with this following diagram. I am here showing a benign tumor in the heart. You're all aware that the commonest tumor of the heart is metastasis. That's going to be mostly from lung cancer, or it could be breast cancer metastasizing. But we will now discuss a benign tumor of the heart, that is atrial myxoma. It is a pedunculated tumor. What I mean by pedunculated is it will have a stalk. So this is a pedunculated tumor. It has a stalk. It is freely floating in the lumen of the left atrium. It has a stalk by which it is suspended, freely floating in the left atria, and in a way effectively blocking the inflow of blood towards the mitral valve. Therefore, when the blood enters into the heart during the phase of rapid ventricular filling, you can see on the right hand side it can enter very straightforward, very easily, because there is no mass effect, there is no tumor present. But on the left side, when the blood will enter like this, it will strike this tumor, which will cause this tumor to swing like a pendulum. I'm now showing in the same diagram that due to the blood hitting the tumor from behind, the tumor will swing like a pendulum and it will go and hit this mitral valve leaflet, resulting in an auscultatory finding which is of interest to me, and that is called as tumor plop sound. The topic that we are studying right now is called as atrial myxoma. The highlight of this topic is the auscultatory finding of the tumor plop sound. It is created. Why? Because the tumor goes and hits an open mitral valve. In fact, if the tumor is becoming bigger, like let me say the tumor size has become relatively bigger, it might be as small as a pebble that becomes bigger like a golf ball. So imagine a tumor as big as a golf ball, or the tumor is exhibiting a mass effect. Like if this tumor is relatively bigger, then you can see that it will also limit the inflow of blood in the mitral valve. The surface area of the mitral valve is approximately 4 to 6 square centimeter. So I can say that this tumor will behave like, or it will result in manifestations like that of mitral stenosis, because the inflow of blood into the heart of the patient is substantially reduced. If less would go in, less would come out also. Atrial myxoma is the most common benign tumor of the heart. The auscultatory finding that I've taught you here is called as tumor plop sound. The sound is created when the tumor goes and hits. And do remember these words that I say. The tumor hits an already open valve. When I'm saying already open valve, that means the heart is already beginning to relax, because I told you the filling of blood occurs in the phase of diastole, especially rapid ventricular filling. So the tumor hits an already open mitral valve. Why that is important for you to know that already the mitral valve is open? Because opening of the mitral valve is called as opening snap. So the sound that is called as tumor plop sound will be heard after the opening snap. I repeat that again. First the valve will open, then the tumor will come and snap. It will come and hit the valve from open. The valve is in the phase of opening, the tumor comes from top and hits from the top. So first you will have opening snap, then you will be having a tumor plop sound. So tumor plop sound will always occur after the opening snap in the patient. Let's make it a little more clinical, because nowadays the focus is on clinical based questions. So he will mostly begin by describing a young female. He will say that this young lady, she is having complaints of effort intolerance. She says that earlier I could climb the stairs of my house 10 times per day. Now going up and down even once is a Herculean task for me. So she says that I get tired very soon. And initially I might think that she's having anemia, or she's having some nutritional deficiency because of which she's not able to do any physical activity. And in this patient, I'm not realizing at the moment that the reason for the effort intolerance is less blood coming in the left ventricle because of the obstruction which is caused by the mitral valve leaflets in the patient. So initially I might prescribe her iron supplements, etc., but the symptoms of her are not relieved. In the next consultation, when she came back to me after 15 days, 20 days, or maybe 1 month, the tumor will obviously increase in size, and there's a possibility that after maybe 1 or 2 months or subsequently, the tumor might be causing substantial amount of physical obstruction present here to cause congestion in the left atrium. This congestion in the left atria will cause congestion in the pulmonary venous circuit. So I've just modified the diagram now to show the congestion is occurring in the pulmonary venous circuit. This will also result in development of congestion in the lung circuit of the patient, that will translate into development of pulmonary edema. This lady, who was earlier telling me that she gets tired very soon, now is also telling me a very peculiar finding. She says, I also get breathless, and the severity of breathlessness is also increasing. Earlier, it's a possibility that the breathlessness was coming only on climbing stairs, but now it is like even going to bathroom, etc. That she says, I just feel so breathless, doctor. So she's seeking my medical advice today. What will catch the attention of any physician, any doctor, or your attention in the MCQ will be the next words that will be written in the question or the words that this person will say. I want you to imagine that this person or this lady is sitting on a chair next to you. Due to gravity, the tumor will go down and will physically obstruct this opening. So the congestion part will definitely increase when the person is sitting up. However, imagine the same person is now lying supine. On lying supine, the tumor will move away because the effect of gravity will be cancelled and more blood will be able to go in the left ventricle. What I'm explaining you is that in patients of atrial myxoma, the symptom of breathlessness is increased in sitting position. Why? I repeat again. When the person is sitting up like I am at the moment before you, due to gravity, the tumor will go and physically obstruct the opening or the inlet of the mitral valve. But if I'm lying supine, then the effect of gravity is cancelled and therefore the pressure or the obstruction is relieved. Do remember the fact that the technical word and the catch in the MCQ, because if they give you 2 or 3 liner questions where there's a clinical history given, in every clinical based history question, there will be 2 or 3 pointers that will immediately tell you that, okay, this is an answer to this question. So in case you come across a question like this, which uses this technical term platypnea, meaning of the word platypnea is breathlessness of the patient is increased in sitting position. Why this is important for you is because simply that in cardiology we tend to focus on the word orthopnea, which is breathlessness in supine position. Orthopnea is what you get in a routine case of acute congestive heart failure. But here we're not talking about congestive heart failure. We're rather talking about a tumor that is physically blocking the inlet of the mitral valve. Therefore, platypnea is a very good way to solve this question. Now, on listening to her history, including this platypnea complaint, I have decided to examine her. On auscultation in this patient, one of the very characteristic finding that is heard and has been told to you already is called as tumor plug sound. I want you to remember the tumor plug sound is a low pitch heart sound. Because it is a low pitch heart sound, therefore, this can be heard only with the smaller side of the stethoscope, which I explained to you is the bell. Based on this, I want to highlight the fact that there are only 3 low pitch heart sounds primarily. The 3 low pitch heart sounds are, and I've explained to you 2 on my previous slide and 1 I've just explained to you, so I will write it down for your convenience. 3rd heart sound, 4th heart sound, and tumor plug sound are low pitch heart sounds. Apart from these, all others, whether I say it or I don't say it, it is implied that they are high pitch heart sounds. I repeat my statement. There are 3 low pitch heart sounds in auscultation with respect to heart sounds. 3rd heart sound, 4th heart sound, and tumor plug sound. They are the ones which are going to be heard with the smaller side of the steth. All other heart sounds are going to be implied high pitch heart sounds, and here I've done a color coding also to highlight that the ones in blue are high pitch, that is diaphragm, and the ones in red is the bell. And the new thing that I've added is tumor plug sound. I hope you are remembering that tumor plug sound will be heard right after the opening snap. Why after the opening snap? Because first the valve should open, at the same time the tumor is showing a downward movement, so it comes and hits, and that is when you could be having this manifestation of tumor plug sound occurring in a patient. In fact, lots of time, a lot of doctors might even misdiagnose this patient as that of mitral stenosis. Though this person, because one of the common causes of mitral stenosis, especially in India, is rheumatic heart disease. Why? Because in these patients, since the opening is becoming relatively smaller, secondary to the tumor which is obstructing most of the blood, there can be turbulence at the level of the mitral valve inlet. I repeat my statement. I'll just zoom it in so that I can highlight that part again. What I'm saying is that in this person, as the tumor will come down towards the mitral valve leaflet, it is literally behaving like mitral stenosis. You all know the concept of physics that if the opening is small, if liquid goes through a narrow opening, it produces turbulence. So there is a possibility that in this patient, you might be able to hear a mid or a late diastolic murmur also. Mid to late diastolic murmur, why I'm saying this is primarily because of the fact that it will start behaving like mitral stenosis only. The inlet of the mitral valve is becoming relatively small because there's a massive tumor that is coming from the top. So it is reducing the inflow into the valve per se. It is reducing the volume of blood. But at the same time, when the opening is small, there is an increase in turbulence also. So a mid to a late diastolic murmur can be heard in this patient, resulting in a misdiagnosis as mitral stenosis in this patient. In the lung auscultation of the patient, there can be crepitations. These crepitations initially might be heard over the lung basis only. So initially he might say basal crepitations, but as the disease will progress, then you could be having crepitations in both the lung fields of the patient. I have here written bilateral fine crepitations / crackles. Those are like if you open a Velcro tape, the sound that is produced when you open a Velcro tape would be called as crepitations or crackles, and this would be a finding suggestive of pulmonary edema. The investigational choice for diagnosis of this condition is a echocardiography. Now, should I do a transthoracic or should I do a transesophageal echo? Then do remember that for ventricular side, it is transthoracic, which is relatively better. But to identify something that is in the atria, because in this diagram is a two-dimensional diagram, atria are rather posteriorly situated. So transesophageal echo is superior for specially identifying atrial pathology. Once I know it is a tumor, then I have to plan surgery for this patient because as such there is no medical treatment for this particular case. To relieve the pulmonary edema component, I can obviously give diuretics to the patient initially so that the person is relatively better, but I will anyway have to refer this patient to the Department of Cardiothoracic Vascular Surgery, where a surgical resection of this person's tumor will be done, and that's the only cure that we can give to this person. And if the surgery is done on time, then I would say that the prognosis of this condition is excellent. Obviously, the tumor starts causing substantial amount of obstruction, or the tumor causes embolic effects, because you see when the tumor mass keeps on expanding, the cancer cells that can embolize from here can contribute to even transient ischemic attack kind of a manifestation in a person. So do not be surprised if in the same MCQ they might give you a TIA attack manifestation. TIA is transient ischemic attack. The neurological symptoms of like sudden onset aphasia or maybe a weakness in one hand lasting for few seconds to few minutes, maybe up to half an hour, could be given in this question just to make you think that this question is related to something from neurology. But I want to just tell you that a neurological complication of this condition is embolism that could occur secondary to a tumor which is present. It could be cancer cells. Cancer can contribute to thrombus formation because after the tumor is causing obstruction in the left atria. So there could be stasis, there could be clot formation in the left atria, and that can embolize into systemic circulation. So transient ischemic attacks could be described in this question. I'm just putting a plus minus here. That's a distraction for you in the question. The clinching point, the main point for you in the question would be the word platypnea. Now, I would like to mention a differential diagnosis of this condition. So look at the next diagram and compare with the previous one. In this case, I'm again showing a tumor which is present in the related to the heart valves only. But if you compare the previous and this diagram, this time I'm showing the tumor originating from the valve leaflets. The last time I was showing a tumor originating from the interatrial septum that was going down and obstructing the inlet of the mitral valve. Now you can see a very distinct tumor which is originating from the valve leaflet. This condition or this tumor is itself described as a MCQ or is asked as a MCQ. It is called as papillary elastoma. The theory to be remembered by you is differential diagnosis of atrial myxoma is papillary elastoma. This tumor originates not from the interatrial septum, it originates from the valve leaflet. Therefore, what you have to understand is that for this condition, there is nothing like a tumor resection that would be done because this will destroy the valve leaflets. So in this condition, we will have to put in a prosthetic heart valve in the patient. There is no point of going in for any surgical repair. Valvuloplasty will not help in this condition because the tumor, by the time it is diagnosed, it would have destroyed and deformed the valve leaflets. A deformed valve leaflet cannot coapt like normal. Therefore, there could be even MR manifestation, mitral regurgitation manifestation in the patient. This condition is a differential diagnosis of atrial myxoma called as papillary elastoma, and the origin is from the valve leaflets. Apart from this, I have already taught you that the most common tumor of the heart is metastasis. Normally, this information is given in the end of cardiology section, but they have picked up questions from there, so it's okay, fine. We should be aware of it, that oat cell cancer can metastasize to the heart. Breast cancer can metastasize to the heart. So is malignant melanoma. In a case-based scenario, he will be describing a patient having maybe even a malignant pericardial effusion. So whenever he gives you a question of a malignant pericardial effusion, which might become so big that it might even cause a tamponade, because you see the effusion will keep on increasing, crushing on the heart from outside. It will press on the heart from outside. The intrapericardial pressure will increase dramatically. It will squeeze the heart from outside, so the filling of blood in the ventricles will be compromised. So the same patient of metastasis to the heart can present with cardiac tamponade. Cardiac tamponade will be discussed subsequently, but I just wanted to tell you the importance of knowing this information, that in a question of cardiac tamponade, one thing that should always click is this person having a cancer which has come from somewhere else, metastasized to the heart, crushing the heart from outside. If the question is asked as what is the most common primary malignant tumor for the heart, well, for this one, there will be no clinical based question. This is just a fact. Primary malignant tumor of the heart. The common error that I get from most doctors as an answer is rhabdomyosarcoma. Do remember that's an answer in pediatrics. If they ask you in children, commonest primary malignant tumor of the heart in children, it is rhabdomyosarcoma, no issues. In pediatrics, you see lots of time rhabdomyosarcoma is an answer. Like in eye also, rhabdomyosarcoma happens to be an extraocular tumor. In the heart, it is obviously important primary malignant tumor in children. But in adults, the answer is angiosarcoma, and the benign one I have already explained to you, that is atrial myxoma. The auscultatory finding of atrial myxoma has been highlighted as tumor plop sound. It's a low pitch heart sound. The clinical finding, which is very specific, is platapnia, breathlessness in sitting position in the person. And you will also or can possibly have a murmur in these patients in the later stages. Even TIA manifestations can be given in the question. Differential diagnosis of atrial myxoma has been highlighted right on the top, that is papillary elastoma. The objective of this discussion is basically to sensitize you to heart sounds. Here I have just used this opportunity to describe a tumor of the heart before you, but the main focus in this entire discussion has been to explain to you the concept behind development of tumor plop sound, which is a diastolic finding. Now, the topic that we're discussing is still heart sounds. To incorporate one more extra abnormal heart sound, I will now be discussing regarding tubercular pericarditis in a patient. This is a form of extrapulmonary TB. You guys are aware of the fact that the most common form of extrapulmonary TB that you see in your clinical practice or regularly cases come in your OPD is that of cervical lymphadenopathy. Why do you have cervical lymphadenopathy? Is because the tonsils of this person were seeded by the TB bacteria. Like a person was having TB, he's an open case of sputum positive case of TB, is coughing on the other person and the TB bacteria landing in the tonsils. This is itself a question that I've introduced incidentally here. Site of Ghon's focus in tubercular cervical lymphadenopathy is the tonsil. The jugulodigastric lymph node will then become bigger and so big that sometimes it can rupture and even cause a cold abscess formation. Another form of extrapulmonary TB is mentioned on the board as tubercular pericarditis, where standard features of TB can be given in the question, and then he will talk about manifestations of tubercular pericarditis per se also. Routine features of TB can be like the person says that I wake up in the middle of the night with cold sweats. Night sweats could be described. Evening rise of temperature or low grade fever can be described. He is having involuntary weight loss. Involuntary weight loss is itself a question. The MCQ said how much percentage of weight loss over how much time. According to the current edition of Harrison, involuntary weight loss is defined as decrease in the weight of a person by at least 5%. Do not answer 10%, it is 5% or 10 pounds. It is written as 10 lbs, that is in the American system, pounds is written as lbs. So it is 5% decrease in weight over a span of 6 months, that we call it involuntary weight loss. Because there will be involvement of the pericardium, there would be involvement of the phrenic nerve, so the person will also be experiencing chest pain, which is a surprising feature for any patient of tuberculosis initially. Therefore, I will be now auscultating this person who's having this symptom of chest pain at rest, and an auscultatory finding that I shall be obtaining is pericardial friction rub. You see, there is inflammation between the outermost layers of the heart. There is a serofibrinous exudate here. This results in generation of pericardial friction rub. And we will now have to differentiate a pericardial friction rub in the MCQ from a pleural rub. Pleural rub is heard only in the phase of inspiration, but pericardial friction rub can be easily differentiated from pleural rub by breath holding. Please appreciate that if a person is having a scratchy sound in the chest, which you are suspecting could either be pleural rub or pericardial friction rub, what advice will you give? You will ask the person to hold his breath for a few seconds, and when he's holding his breath, you will notice that the sound will still be persisting. Do remember that when the person will hold his breath, lungs are not working at that point of time. You just have to hold your breath for 5 seconds or count mentally till 5 in your mind and hold your breath for 5 seconds or whatever you can, and the sound is still coming. That means sound is not coming from lungs, it is coming from the heart. So this was itself a question. What is the best maneuver to differentiate pericardial rub from a pleural rub? Options were like deep inspiration, deep expiration, forceful inspiration, and breath holding. The best maneuver to differentiate between a pericardial rub versus a pleural rub is breath holding. And if the sound persists, that means it is coming from the heart because the lungs are not working. On the other hand, pericardial friction rub can be easily differentiated from pleural rub because pleural rub is heard mainly in the phase of inspiration. Once I've auscultated this person and I'm getting this finding of rub, it is my job now to do a quick ECG because any person with chest pain ECG should be done. A very characteristic ECG finding of pericarditis can be given in the same question, which will be a development of ST segment elevation. You are aware of the fact that ST segment elevation is found in myocardial infarction also, but in this case you will notice that the ST elevation which is present will be relatively concave upwards. In myocardial infarction, the ST elevation is always convex. I'll just sketch it before you. In myocardial infarction, this ST elevation will be also associated with the T wave inversion. It could also be having a deep Q waves, but one of the highlights, because the images in the exam are very clear, is ST elevation which is convex upwards. This is also called as Pardee sign. Pardee sign is a very classical feature of myocardial infarction. The finding would be called as TEMI, ST elevation myocardial infarction. It is also called as tombstone pattern. So whether you read Pardee sign, tombstone pattern, or simply ST elevation convex in an upward direction, it highlights that the patient is having myocardial infarction. On the other hand, if there is a ST elevation concave upwards, it is pericarditis. There are other differences also because pericarditis is present all around the heart, 360 degrees. So there are 12 leads ECG that you perform. In pericarditis, you will get findings in almost 11 out of 12 leads. Remember, in myocardial infarction, the findings are found only over overlying leads. Like for example, person is having lateral wall MI, so findings will be found in lead 1, then AVL, then V5, V6, because those are the leads that study the lateral surface of the heart. If it is posterior wall MI, the findings would be found in like V7, V8, V9. So the point is, in myocardial infarction, the ECG findings are limited to only few leads, but pericarditis is a diffuse manifestation. It's all around the heart. So 11 out of 12 leads will be having a ST elevation. You might even say the word except here. The except would be given by you as AVR. AVR is one lead in which the first wave of the ECG, the P wave, as well as the T wave, both come upside down. Do remember the fact in a normal person's ECG, the first wave of the ECG, P wave and T wave, is always negative. It is upside down in AVR. So in this person, you will be able to get a reciprocal change of ST segment depression. This is how the ECG of the same pericarditis person will appear to you in lead number AVR, which reads the heart the other way around. What I mean by reading the heart the other way around is, it reads the P wave upside down and the T wave upside down, and therefore the change would be also a ST segment depression. So don't be surprised if he mentions ST segment depression deliberately in this question in only one lead. That is just to see whether you are aware of this concept that in pericarditis of any etiology, if it is acute pericarditis, it could be tubercular, it could be bacterial pericarditis. If there's a pericarditis, there will always be of acute. The word is acute, right? Not constrictive. Acute pericarditis will always be having a ST elevation which will be concave upwards in 11 out of 12 leads except lead number AVR. Now, once I've demonstrated pericarditis on basis of two things, one is the auscultatory finding, second is the ECG finding, I also need to be sure that this is tuberculosis. A large number of these patients can also be having pericardial effusion developing subsequently. So if I do a echocardiography in the patient, a pericardial effusion, a minimal pericardial effusion may be seen in the patient. You see, normal pericardial space contains 20 to 50 ml fluid for lubrication purposes. Here, because there is the inflammatory part, so the fluid can be more than 50 ml. So pericardial effusion may be demonstrated, minimal pleural effusion may be written. Once I've identified that yes, there is a problem with the heart of the patient, I now need to demonstrate it is tuberculosis. Obviously, in a person who's having extrapulmonary tuberculosis, there could be positivity with Mantoux, there could be X-ray findings in a person, but sometimes Mantoux might not be positive, X-ray may not be positive. So what test will you do to identify that this case is having extrapulmonary TB? Then in these patients, maybe you can use pericardial fluid or any body fluid to evaluate for presence of Mycobacterium tuberculosis. What test will you do on the pericardial fluid if available in this case? The test that you will do will be called as CBNAT. You are now aware of the fact that CBNAT, which is written in American books like Harrison as gene expert. So whether you say gene expert or whether you say CBNAT, that is cartridge-based nucleic acid amplification technology, is the best test for diagnosis of pulmonary TB. In pulmonary TB, we use sputum. In extrapulmonary TB, we can be using pericardial fluid. In CSF, in tubercular meningitis, we could be using CSF, CBNAT in the person to demonstrate. So if I do this test CBNAT on the pleural fluid of this person, which will be done by echocardiographic guided pericardiocentesis, we remove the fluid, then CBNAT, if turns out to be positive, that will definitely tell us that this person is having a tubercular pericarditis, and then I can initiate ATT treatment in the patient. The good news is that the anti-tubercular treatment of this person has been started. The duration of anti-tubercular treatment will be 6 months. You are aware that in extrapulmonary TB also we give anti-tubercular treatment for 6 months only. Once I've given the treatment for this person, the symptoms of TB will begin to regress in the first few weeks of treatment only. The good news is I have treated this patient medically. There is a substantial improvement in the symptoms of tuberculosis, but unfortunately in these patients a complication can start developing, which I'll try to explain to you in the next few seconds. Let us take this to be representation of the ventricles cavity of the left as well as the right ventricle of the patient. On taking my anti-tubercular treatment, the good news is that the TB symptoms tend to come down, but a new problem will develop in this patient, which is the development of a thick zone of calcification. Like you have a eggshell like that, I have shown here a substantial amount of calcification developing around the heart of this person, and this will encase the heart from outside. It will limit the filling of blood in the heart from outside. If I compare this with a ventricular cavity of any one of us, I've shown a much more better oriented ventricular cavity in the second diagram. This is ventricular myocardium. The inside is the endocardium, pericardial sac. If you look at the ventricular cavity of a normal person and then evaluate the hemodynamics, while you and me are sitting on a chair comfortably, the end diastolic volume is about 130 ml. When the blood enters into our ventricular chamber, it hits the myocardium. Our ventricular myocardium can easily get stretched. It is compliant. It is compliant because there is no calcification around it. Therefore, I have shared or highlighted that in you and me, every time our heart is receiving blood, the ventricles are getting slightly dilated. This compliance of our ventricles is always present and ensures a substantial filling of blood in the heart. However, in this person, I have shown a tapering arrow 1 to show that the amount of blood that can come in the ventricular cavity of this person is relatively lesser, because unfortunately he has developed a zone of calcification outside the heart. What I'm teaching you at the moment is development of constrictive pericarditis. This is a complication, or it is a sequelae of tubercular pericarditis. I repeat my statement once again. Constrictive pericarditis is characterized by calcification around the heart. It is a sequelae or a complication of a treated case of tubercular pericarditis. Remember, not untreated. If you don't treat tubercular pericarditis, it will cause a pericardial effusion. It can then even cause a cardiac tamponade in a person. So you will get cases of tubercular pericarditis who could either present in tamponade due to being undiagnosed for a long duration, or there's a possibility that you treated the person and now he has developed a calcification around the heart, which will limit the filling of blood in the heart, and therefore due to the calcification around the heart of the patient, the following event will occur. See very carefully, the blood is hitting the myocardium from inside because it wants to dilate the heart, distend the heart, because after all volume of blood is coming in, so the ventricle should get dilated. But when the blood hits this muscle, it tries to dilate but fails miserably. Why fails miserably? There's a non-compliant ventricle in the patient. The blood hits the muscle, bounces off. Blood hits the muscle, rebounds, and therefore there can be some turbulence created in the ventricular cavity of this person, and this turbulence is the main reason that I had to go into this entire long discussion. And the auscultatory finding that I'm teaching you now is called as pericardial shudder. Guys, pericardial shudder can sometimes be so loud that you can even appreciate it by keeping a hand on the chest of this person. You will be able to feel the turbulence under your palm. Pericardial shudder is also called as pericardial shock. In fact, most examiners will love to use the word pericardial shock because they want you to confuse this with the routine kind of shocks, no? Hypovolemic shock, distributive shock, obstructive shock. He can say the word pericardial shock, he can say the word pericardial knock. Please remember, pericardial shudder, shock, knock, all three mean the same. They are auscultatory findings with the same concept. They are found in patients of constrictive pericarditis when during the phase of diastole, because whenever you are having filling of blood in the heart, it is obviously a diastole that is going on. So pericardial shudder is a diastolic finding. Let's time this a little more, so pay even more attention than what you're paying right now. If you look at the normal side, I have shown now mitral valve. Let us imagine this is the left ventricle. I have shown the mitral valve to be open. When the mitral valve will open, I'm putting one here to say that opening of the mitral valve is what I taught you is called as opening snap. So in a normal person, first you have opening snap, then blood goes in, it dilates the muscles of the heart of yours and mine and is able to distend the heart in a normal person. I will say the same thing for this patient also. Mitral valve is open, so I've just put a 1 here. It simply signifies that opening snap has occurred in the person. Now blood will go inside, hit and bounce off, and that creates turbulence, which is called as pericardial shudder. So pericardial shudder will always occur after the opening snap. I repeat my statement. First the valve will open, blood goes inside, so opening snap has already occurred. Now the blood will go inside, hit and bounce off. So pericardial shudder will always be heard after the opening snap. Now what is heard after the opening snap? After the opening snap comes third heart sound. Remember I drew that cycle before you. First you have second heart sound, opening snap, third heart sound, fourth heart sound. So pericardial shudder always occurs after the opening snap, and because it can occur at the same time as that of third heart sound, pericardial shudder can mimic third heart sound. I repeat my concept once again. What I said was, first mitral valve will open, that is opening snap, then blood will go inside, hit and bounce off. So pericardial shudder is always heard after the opening snap. What is heard after the opening snap in a normal person? Third heart sound. So you could get confused. Are you hearing third heart sound? Are you hearing pericardial shudder? How do you differentiate two different sides of the stethoscope? Third heart sound, as I explained to you, is a low pitch heart sound, so you will be using bell. And pericardial shudder is a high pitch heart sound. This is best heard with the help of diaphragm. The learning message for you is that pericardial shudder as well as third heart sound occur at the same time, but they are not heard with the same side of the stethoscope. To hear a third heart sound, you need to use the bell. To hear the pericardial shudder, you need to use the diaphragm, and my basic message still remains the same. All heart sounds are high pitch except only 3. Remember, third heart sound, fourth heart sound and the tumor plug sound are the only 3 low pitch heart sounds. All others are high pitch heart sounds. So if you remember the line that I said initially, you are right, or you are bang on target to solve even a question related to pericardial shudder and its timing. Remember, pericardial shudder mimics third heart sound. On the basis of this, now you will be in a better position to understand this sequence of events. So let's practice this again. I have today taught you that you will be able to hear the lub-dub heart sound like this, S1, S2, S1. Do remember, right after S1, you get a finding that is called as ejection click. After second heart sound, you have is a opening snap. In case you have forgotten, I repeat again, loud opening snap, mitral stenosis. But at the moment, it is the sequence that you need to remember. After this, there would be a presence of third heart sound in a patient. They could be fourth heart sound, yes, if there is a problem like there is a left atrial hypertrophy due to hypertension, fourth heart sound can be heard in hypertension patients. Any condition where there's an outflow tract obstruction, fourth heart sound would always come in the patient. Now, in the same diagram, we will make some additions. One of the additions to be made is a heart sound that occurs at the time of third heart sound. We just discussed, this is pericardial shudder. This is auscultatory finding of a calcification around the heart for constrictive pericarditis. Another finding that I've taught you is right almost occurring at the same time, but still occurring after the opening snap, because rapid ventricular filling should occur. That's when the mitral valve should open, only then blood will go inside. So this green arrow that is present here is for tumor plough sound. Tumor plough sound is used for diagnosis of atrial myxoma along with clinical finding of platypnea in the patient. And now I'm introducing abnormalities which are called as mid-systolic clicks. Please do not confuse it with ejection click. That's a normal finding. It is mid-systolic clicks which are going to be heard in patients of MVP, that is mitral valve prolapse. This is a diagram which I want you to ideally hand draw by yourself so that the sequence becomes oriented in your brain, that what comes before and what comes later. You can see in the diagram that majority of the information is cluttered in the diastole component. In the systole, you can just see ejection click which is normal and mid-systolic clicks which are grossly abnormal. But do try to hand draw this diagram so that the sequence is very clear before your brain. I can once again remind you, what is heard right before S1? Fourth heart sound. I mean, you should not have to look at the options in the question. You're reading the question and mind it is clicking, okay, this comes before, this comes later. So the main objective of the discussion is to sensitize you to the sequence of events. If you practice them, obviously with practice, we all become perfect. So this is the information that I would like you to remember for this particular lecture.